Hi, this is Brian Kim. I'd like to share with you this case of a white intumescent cataract that led to an Argentinian flag sign. Now, you've heard me in the past say that in these cases, they don't tend to propagate posteriorly. I haven't had the experience where the patient ended up having a posterior capsular tear, a wraparound, or vitreous loss, or lens loss. And I believe it's because these forces that cause the radialization of the tear are mainly anterior. And so once the split occurs, the lens and the intralenticular contents come forward and it releases this pressure. And so the tear only goes just short of the equator, in my experience. But nonetheless, these are scary, and so I'll show you how I handled this case. I use my corneal marker to help me size and center my capsular rhexis. I make my paracenteses incisions, and then fill the eye with intracameral lidocaine. I'm placing intracameral air, and then I'm placing trypan blue to paint the anterior capsular surface. I don't like to paint too vigorously. I like to just pulse a little bit and then literally use the cannula almost like a paint roller, and I like to paint the anterior capsular surface with the trypan blue. Filling the eye too aggressively can cause the dye to propagate into the vitreous space in the case of weak zonules. I'm injecting dispersive viscoelastic to fill the anterior chamber, and then I perform my triplanar corneal incision. I make a vertical groove and then tunnel and then enter the anterior chamber. So this is my first mistake. I underestimated the intumescence, and then when I punctured with my forceps, you got the Argentinian flag. So you have to be proactive and err on the side of precaution with these cases. What I would have done alternatively was to inject the center with a 25 or 27 gauge needle and then aspirated the milky material and then tried to make a small capsular rhexis. You can also use the blunt side of a cannula and kind of express and milk some of that milky material towards the anterior capsular opening when you puncture it with a needle. And that allows the material to come out, and this helps you flatten out the anterior capsular surface. But that doesn't help me for this situation now, so we're going to have to come up with a solution. And so now I'm trying to grab the capsule flap, and I'm seeing if I can propagate this, but this one clearly went more posterior to the, maybe just short of the equator, but it's definitely on the periphery, and I'm not able to use the little maneuver to rescue this rhexis. So I switched gears and went with my micro scissors, and I cut a little bit of a flap here, and then started my capsular rhexis. Now what I didn't do was fill the eye with more dispersive viscoelastic, and as I tried to propagate this tear, it caused it to radialize as well. And so I'm pulling and pulling, and this is the same as the other side. I'm not able to use the little maneuver to really pull this rhexis back towards me. I'm using various maneuvers and efforts to try to kind of pull this towards me. I'm pulling and pulling, and still nothing happens. And so I go back with my scissors to create another flap for my rhexis. I'm finally able to propagate this rhexis and go ahead and make a continuous curvilinear aspect of this side of the rhexis. I'm performing my capsular fornix hydrodissection technique, but picking a spot that's away from the anterior capsular tear. I lift my corneal incision and enter with the phaco tip and then the chopper, and then remove the surface epinuclear material. I try to carefully go around the lens material with the chopper, and I try to perform the double chop maneuver. I'm trying to be very cognizant of not getting out near the capsular bag because there is a tear there. I'm pulling the lens towards the center using the vacuum and then crushing the lens in between the chopper and the phaco tip. I'm trying to be very careful and cognizant not to put any pressure on the bag or the zonules. Any pressure, if I was sculpting or pushing down on the lens in any way, it would propagate forces to the capsular bag and to the zonules. So every force, every maneuver I'm doing is towards the center. So I'm, again, pulling lens material towards the center. I'm grabbing pieces with the vacuum to pull up. And so you see I'm able to free this one quadrant, and then I'm carefully crushing it between the chopper and the phaco tip, and then aspirating and emulsifying the lens piece. I continue to go around, trying to find mobile pieces to grab. I found another piece here, and I crushed the lens between the chopper and phaco tip and emulsify this piece as well. I'm getting a sense that there's a fairly opaque epinuclear shell. I'm just rotating the lens pieces towards the center. You saw that move. I'm using just mechanical forces to tease the lens out of the bag and then grabbing it with some vacuum to center it. And then I'm just crushing the lens between the chopper and phaco tip. Again, breaking the pieces into smaller sizes and then using vacuum and ultrasonic energy to remove the lens pieces from the bag. I'm using the chopper always to protect the bag as I'm using the high vacuum to try to grab some of these pieces. There's the final quadrant is left in the lower right corner. I'm using vacuum to help kind of tease up that quadrant, and then it comes forward. And then I'm going to use the ultrasonic energy and vacuum to remove the lens pieces. Again, in the meanwhile, using mechanical fracturing forces to crush the lens material into smaller pieces. So getting back to this epinuclear shell, how am I going to get this piece? I have a discontinuous capsular bag. I definitely don't want to push on it. I don't want to suck it. If I suck it, I might grab the bag. If I try to sculpt, that would definitely be bad because the posterior capsule is right underneath me. And so this is what I do. I have a lot of faith in my technique with my hand and the chopper. And what I'm going to do is just go around the lens material, knowing that I'm definitely not going to tear the bag or propagate the tear at all with this maneuver. And I'm going to basically go around with the chopper and hook the epinucleal material. And when I do that, you can see it pulls up nicely and it pulls up into the iris plane. I'm able to pulse with a little bit of vacuum and then basically mobilize that piece of epinucleal material. So we're doing gentle phaco even in the context of a discontinuous bag with these mechanical fracturing forces without putting any pressure on the zonules or the bag. You're able to still take out this pretty dense white lens. I push BSS into the eye and then take the phaco tip out and switch to the INA handpiece. In the case of zonulopathy, you have to be pretty careful with your technique of pulling the cortex out. However, in the case of a discontinuous capsulorhexis, the main thing is making sure that you're pulling on cortex and that you're not pulling on the bag itself. And so you can see I'm gently going around and pulling on the cortical material very gently. Even in the areas of discontinuous capsule, I'm able to go around and still very confidently remove the cortical material. I'm filling the capsular bag with cohesive viscoelastic and then going straight to the single piece acrylic intraocular lens. I'm going to make sure that the haptics are going to be perpendicular to the areas of the discontinuous rhexis, which means they're going to be side to side from my main incision. Because of the discontinuity of the capsule, I'm going to go ahead and use a second instrument to make sure that the haptics are within the bag and then gently dial and rotate the haptics again 90 degrees from the area of the tear. I injected some more cohesive viscoelastic around and into the bag and then using a Maltzman to make sure that this haptic on the right side is definitely within the bag and around the area of capsular tear. This patient also had glaucoma, and so I'm placing an Istent into the eye. You want to make sure you stab into the trabecular meshwork, rotate your hand. You can see my hand went from the left to the right side, and then once you flatten out, once you're parallel to the trabecular meshwork, you advance the Istent and it slides right into place. So I'm gently removing viscoelastic from the eye. You can see that the anterior capsule edges are covering on the left and the right side, and the haptics are along the axis of the intact capsule, and the IOL is well centered within the capsular bag. So in summary, intumescent lenses can occur. Even with proper technique, you can get an Argentinian flag, but the first thing you want to do is inject a lot of viscoelastic, flatten the anterior capsular surface, make a small puncture incision with a needle, aspirate the milky cortical material. You can even go inside the hole and aspirate out with the BSS cannula. You can make a tiny rhexis and then remove more lens material and then enlarge the rhexis afterward. But as I've stated before, sometimes you get an Argentinian flag despite your best efforts. And it has been my experience that even though these propagate and tear anteriorly, these hardly ever propagate posteriorly. I have never had an Argentinian flag propagate posteriorly and lead to vitreous loss or lens material. I do believe that using mechanical fracturing forces with my techniques and applying only centripetal forces towards the center, away from the bag and the zonules, does help me minimize any complications in these situations, and it could be why I haven't had any complications with this situation. So I hope this case was helpful to you, and thank you for your attention.